All right, everybody, thank you for tuning in to Superior Arts' video presentation. It is now my distinct pleasure to introduce Dr. Rajeev Ramchand. Dr. Ramchand, our first keynote speaker, is co-director of the Rand Epstein Family Veteran Policy Research Institute and senior behavioral scientist at the Rand Corporation. He's conducted research on suicide and suicide prevention, including environmental scans of suicide prevention programs, epidemiologic studies on risk factors for suicide, qualitative research with suicide loss survivors, and evaluations of suicide prevention programs. In 2022, he was appointed by the Secretary of Defense to serve as a member of the Department of Defense Suicide Prevention and Response Independent Review Committee. He has testified on suicide prevention before the United States Senate, House of Representatives, and California State Senate. He holds a bachelor's degree in economics from the University of Chicago and a PhD in psychiatric epidemiology from the Johns Hopkins Bloomberg School of Public Health. His presentation is titled The Role of Research in Preventing Suicide, Evidence, Context, and Questions, Insights from 4 Case Studies. And as a suicide researcher myself, I am extremely excited to hear this presentation. And Dr. Ramchand, thanks for joining us, and please take it away.
Thanks so much, Mike. And it's unfair having me go right after April and that video. That was really just phenomenally done and really insightful. So thank you for inviting me to be here today. And thanks everyone for tuning in. I'm sorry for my voice, which is a little bit due to allergies, is a little bit struggling, but we'll get through it together. And so a lot of what you said, Mike, in your introduction to today, I hope that I'll be able to articulate some of that in the slides that I'm going to present and in my thoughts today. So we'll just go right into it. So as Mike said, I work at the Rand Epstein Veterans Policy Research Institute within Rand, where we look at veteran suicide prevention and mental health, but also a whole range of other issues, employment, education opportunities. I also served on the DoD Suicide Prevention and Response Independent Review Committee, and then a few other things as I was preparing this talk and thinking about what would make most sense for me to talk to you all about today. I was on the Mental Health and Suicide Prevention National Response to COVID-19, which was an initiative of the Action Alliance, the National Action Alliance for Suicide Prevention. I have been working recently on public health approaches to address violent extremism. I've been fortunate enough to be a member of the Rand Gun Policy in America project, which many of you might be familiar with, and I'll talk a little bit about today. I've done my own research with NIMH on suicide risk among lesbian, gay, and bisexual adults. And I also think a lot about caregiving right now and the role of caregivers in preventing suicide. So it's a huge range of things is what I'm trying to say. And it was very hard for me to distill all of it or to select one. And so in thinking through, what might have been common themes, I really just thought to myself that our research doesn't occur in a vacuum. And what I mean by that is we do the research in context, and sometimes I think we're not necessarily aware of the contextual factors that might impede our research from having an effect. So basically, I think what I'm trying to say is I think that there's a lot of evidence about what we can do to prevent suicide. Maybe not, foolproof ways to prevent all suicides, but there's a lot of things that we know that we should try that doesn't get done. And it's those contextual factors that have become really interesting to me. And I think that that's the common theme in the research that I've been doing, having one foot in the research area and one foot in being on this independent review committee and being part of the National Action Alliance has really enabled me to think through and to identify new research questions that have emerged. And so that's really what I hope to speak to you today. And I don't consider myself an implementation scientist, and I don't necessarily think that I'm going to be talking about implementation science per se, but what I really want to ask is, why are these evidence-based strategies for preventing suicide not being implemented? And then really kind of take it one step forward, and where do I think research can actually help tighten the rope? Because it may not be that the research needs to be implemented. It may be that there are research questions that we haven't yet asked that could be addressed, that could help tighten that gap, that could help get evidence-based strategies into practice. So the way that I'm thinking about this is that often we think that research is a race towards the finish line. And this year I decided for my own exercise that I'm going to try to build my stamina. And maybe that's, as a researcher, what we need to be doing that too, and think about it as a track, and running around the track where we conduct the research, we present the findings, we inform leaders, and they say why that won't work or what challenges they'll see in implementing what we think is effective. And then we develop research questions from that, and then we conduct the research on that. And I really think that through that cyclical process, we might be able to get a little bit closer to implementing evidence-based strategies for preventing suicide. So I'm going to talk about 4 case studies to really kind of articulate this. And I think that that should take up most of the time and still leave time for questions, which I'm really excited to hear. So the first thing I'm going to be talking about is some work that we've done with the Gun Policy in America issue on personal firearms storage practices. Then I'm going to highlight some of the recommendations we made as part of that DoD Independent Review Committee that specifically relate to firearm sales on military installations. Then I'm going to take a step away from talking about gun violence because something that I've been doing, especially since COVID, since the COVID emergency and pandemic came into play, is thinking about suicide prevention in non-clinical settings, and specifically thinking about unemployment, individuals who lose their jobs or at risk of losing their jobs, and what that relationship is to suicide and how those adverse events could be mitigated with that group. And then finally, I'm going to get really epidemiologic. I'm an epidemiologist, as Mike said, and really talk about mortality as a patient-centered outcome. And I'll explain to you what that means when we get there. So the first is, to those of you who are not familiar, RAND has conducted since 2016 an initiative called Gun Policy in America. And this is just a screenshot of our website. And what you'll see at the top is where you can go to find different things: key findings, research review, tools and data. And there's something in there called essays. And I've listed in bullet form underneath the banner all the different essays that are included in the Gun Policy in America initiative. And what these essays do are really summarize the research evidence on each of these topics. Things like gun buyback programs, is mental illness a risk factor for gun violence, mental health care access and suicide, things of that nature. But what I want to talk about today is really briefly the relationship between firearm availability and suicide risk, but also then get into how personal firearms are stored in the United States. So with respect to firearm availability and suicide risk, what we know and what's included in the essay is that people who die by suicide are more likely than matched controls to live in a house known to contain a gun. So we know that suicide risk is elevated among household members where there's a gun present. We also know that changes in firearm prevalence in a region are associated with suicide prevalence in the region. So not only is there a correlation by the number of firearms available and the number of suicide deaths, but that as those numbers change, especially those firearm availability, there's associated changes in suicide rates. And then finally, with respect to storage, our evidence isn't quite as strong as it is with availability, but we have some evidence to suggest that living in a house with a gun stored, and I put this term in quotes purposely as we'll talk about, unsafely, is associated with a higher risk of firearm suicide than living with a safely secured gun. But it doesn't seem, the last time we looked at the literature, that storage practices were associated with total suicides. So the storage practices may be associated with a reduction in firearm suicides, but it doesn't seem yet that those practices relate to total suicides, which we can get to in a bit. But still, this is the question. So the evidence suggests the way that we store firearms is likely a risk factor for suicide, especially within the household, especially for firearm suicide. Yet still, the most recent evidence we have across the country, 30% of American gun owners store at least one gun loaded and unlocked. And I should say that the preferred or the recommended storage practices for firearms, as many of you know, is that the gun is kept unloaded, locked up, and ammunition stored separately. So again, around a third of Americans store at least one gun loaded and unlocked. Around 1/5 of American gun owners store some of their guns unlocked. And 7% of all of American gun owners store all of their firearms loaded and unchambered. And this is really important. And I really just want to highlight this research. It's really important. A lot of research that it really thinks about kind of gun owners as having more than one gun, and we know that that's the case, that many gun owners do have more than one gun. So when we do research on gun owner storage practices, we have to ask and inquire about all of them. And these are two national studies that have been able to do that quite effectively. So again, gun availability, storage practices likely to reduce risk for suicide, but we see that quite consistently, around a third of Americans don't store their firearms in that way, or don't store some of them in that way. There's a ton of approaches that have been tested, and more evaluation is definitely needed because a lot of them have not been evaluated. But there's a lot of approaches to change firearms owner storage practices. So we have what we call clinical interventions, you may be familiar with, and Mike has done a lot of the leading research here: lethal means counseling and safety planning, community level interventions, which is this lethal means counseling but outside of the clinical setting. We know that there's education campaigns, distribution of storage devices, trainings, and then there's policy interventions. There's child access prevention laws, or that requirements that firearms be safely stored or sold with storage devices at local levels. The problem is that there's limited evidence that these things work. We haven't seen a ton of great evidence that any of these interventions really will change, especially adult storage practices. I think there is the strongest evidence to date would be counseling for parents of those by pediatricians or in clinical settings. But we don't have a ton of great evidence that storage behaviors change with any of this evidence. And so I've been curious as to why this may be. And more recently, I've been trying to think of, well, why do we define this as safe? And I have to say that one of my reasons for thinking about this is that I've read a few papers that say, storing all of your guns unloaded and locked up, all of them is safest, some of them is safer, and none of them is unsafe, which suggests like a dose-response relationship. And I said, well, what's the evidence there? So anyway, it made me start really thinking about what is meant by the term safe, and what do we think of when we hear the term safe. So as a suicide prevention person who's passionate about suicide prevention, when I think about safe, I think of safe from suicide risk. But when you look at why people store the guns the way they do, or why they own them, we have around 2/3 of American gun owners own at least one of their guns for self-protection. And 60% of American gun owners think guns make their homes safer. And that's related to how they store their practices. So around 40% of those who believe that guns make their home safer store at least one gun loaded and unlocked. So again, we're seeing this relationship between, well, their storage practices are related to their beliefs about safety. Should their thoughts about safety, where do those come from? That was kind of the next question I asked. Where do Americans' thoughts about safety come from? And we've seen, and the chart on the left is data from the National Crime Victimization Survey, where we've seen a decrease in violent crime over the past 20, 30 years, which is really promising. I mean, there's yearly variations and it goes up sometimes, but in general, it's been going down. However, on the right-hand side, we've seen that homicide offenses, and this is from NIBR's data, and I know that there's limitations with this data source, so I acknowledge that. But at the same time, I think that everyone would agree we've seen murders and homicides go up. So while all violent crimes have gone down, homicides have gone up. But more important than the actual data is, what do Americans think about? Do they feel safe? And the chart on the left is from Gallup, which asks the question, how often do you yourself worry about your home being burglarized when you're there? And Gallup asks a ton of questions about perceptions of safety. But you see this huge increase that around a third of Americans are concerned or very concerned about their home being burglarized when they're there. And more importantly, in 2022, 61% of registered voters said violent crime is very important when making their decisions about who to vote for in the 2022 election. So this goes to show that people's perception, what's on people's mind is not suicide prevention, and what's on gun owners' mind is not preventing suicide. It's protecting themselves and keeping their homes safe from violent crime and the perceived threats. And I'm not sure that our interventions for suicide prevention and for storage are accurately targeting directly these beliefs about perceived threat. So the questions that I'd like to ask that pose questions for me, and perhaps many of you have been doing this work and are involved in lethal means counseling and are thinking about, educating gun owners about the probabilities of having someone in their household die by suicide relative to the probability of their home being attacked from violent crime, from being burgled. But those are both, very extremely rare events too. So comparing events with very limited probability or very low probabilities is also going to be really hard. And in general, people have a very hard time. And I'm an epidemiologist, and I still have a hard time understanding odds and probabilities all the time. And so I really think that this lends us to ask some important questions, which is, how unlikely is it that a person wanting to end their lives will do so if a firearm is not available to them? I think that that's the first question with respect to safe storage. I also think we should really be thinking about, what do gun owners think of when they hear the term safe storage? And should we in the suicide prevention community be changing our vernacular and changing how we think about the storage of firearms? And I've seen that happen recently in some settings, but definitely the term safe storage is still used quite widely. And then finally, I'm really curious as to how exposure to violent crime increases or influences firearm storage practices, especially, we've had these tragic cases of mass shootings that are now being, live streamed and broadcast. It does create sense of perceptions of fear and unsafety, or concerns about safety. And I think that we have to recognize that while we're trying to message from a suicide prevention standpoint, the importance of storing these firearms a certain way, people are inundated with information, accurate or not, real-time information about the threats that they're facing in their communities. So that's the first case study. I'm going to switch now a little bit. I think I'm going well on time, and talk about our work on firearm sales on military installations. So on the left-hand side is the final report that we created from the Department of Defense Suicide Prevention Independent Review Committee. For that report, for that study, there was a group of 10 of us on the committee. We went to 13 military installations, including in remote places like Korea and Alaska, but really all over the United States, across all service branches. And during these visits, we toured the installation, but we also talked to everyone that we could on base. So we talked from the most junior enlisted service members to top commanding officers within each installation. In group settings, sometimes one-on-one. We talked to civilians who are working there. We also went out into the communities to talk about, what is happening in your communities. So we really tried to get a full perspective, and that led us to make 127 total recommendations. I'm not going to talk about all of them, but I just do want to highlight that 14 of those recommendations were specific to firearms. 3 of them were on data collection for personally owned firearms. 3 of them were on training requirements for service members who have personally owned firearms. 2 of them were related to requirements for on-base storage and practices and possession. But the ones I really want to talk about for this discussion are the 6 that were respect to making purchases on base. And just so you know, every installation, and I'm sure that there are many veterans and service members who are on the call right now or on the webinar right now. Firearms are available for purchase tax-free. I just went online, and at the Army and Air Force Exchange Service, 76 retail locations across on installations across the country. So that's the first thing. You can buy firearms on bases, on military installations. So our recommendations had to do with implementing waiting periods, developing a database for recording serial numbers, waiting periods for firearms, waiting periods for ammunition, minimum age requirements, and then discounts for firearm locking devices and command notification procedures. So when somebody buys a firearm, their command is notified that they've made that purchase on base. So these were our recommendations regarding the sale of on-sale firearms. And there's evidence for these. So for minimum age requirements, and I know many of you saw the news today or yesterday about the Virginia law about minimum age requirements. So I know that this is a hot button issue policy-wise. But we, as part of the Gun Policy in America, again, I have underlined the research reviews. We've looked at the evidence for all of these policies, including policies related to minimum age requirements and waiting periods. And if you click on that, I want to show you, what you'll see on the screen. I've cut and pasted it, so you don't see it all in the way, but I'll show you what you see. So you'll see a summary. How do waiting periods affect gun use outcomes? And we look at all types of outcomes. And so for waiting periods, we see that they may decrease suicide and violent crime, and that the evidence for decreasing suicide is that waiting periods decrease total suicides is limited, but that it decreases firearm suicides is moderate. And we have different criteria for ranking the evidence. So again, some good evidence that these waiting periods can reduce firearm suicide. And you'll see, the evidence for those kind of meta-analyses, epidemiologists in the room. On the right-hand side, we provide these forest plots that look at incident rate ratios across all of the studies for the different outcomes and the different ranges. So you can see kind of where our evidence lies and how we made the conclusions that we make. So that's the evidence on firearms or on waiting periods. The evidence on minimum age requirements, again, is moderate. That and we look at both minimum age for purchasing and minimum age for possession. And what we see is that minimum age requirements for purchasing a firearm may decrease firearm suicides among young people, and that the evidence for that is moderate. So we have a lot of good evidence to suggest that these work, and that kind of was informative and helped us lead to these recommendations to the DoD, that they should consider these types of policies for firearms sold on their installations. Now, here's the context that I didn't even understand fully until engaging in this research. So on-base sales of goods and services to military personnel and families go into this pot of money that are called non-appropriated funds, meaning that Congress doesn't appropriate those funds for specific uses. And those funds support DoD morale, welfare, and recreation programs, healthy communities, BFIT families, troop readiness. So things from a suicide prevention program that we also want installations to do. So the money from the sales of products at the exchanges, including firearms, goes to support these different activities and programs. And to make things a little bit more, I just shouldn't say complicated, a little bit more complex, is that we recommended that the DoD fully fund, especially the morale, welfare, and recreation programs. So these are things like excursions for single soldiers, or the bowling alley on base, movie theaters and movie nights, video game events, and things of that nature. Pro-social activities that service members can partake in, usually for free or at a very reduced cost. And again, these are things that we want. We want service members to be engaging in these things so that they're not resorting to more harmful behavior, so that they're really engaging and proactive. And again, so these things are funded by firearm. So there's a tension there that, do we really want to start reducing the proceeds that we're making, which will then potentially result in less funding for these events? So that made me think, and that's made me think for quite a while about, well, essentially, if we were to impose some of these policies on installations for the change of firearms, will we change consumer behavior, or will they just buy their firearms somewhere else? So exchanges offer tax-free firearms, and they're convenient. Everyone goes to base for work, and so some of the people live on base, so you can just buy the firearm on base. But a lot of places don't have waiting periods. There are federal waiting periods, but a lot of states don't have waiting periods, and a lot of states don't have minimum age requirements that exceed those of the federal limits. So, so people may not be subject, if the DoD were to apply these restrictions to on-base sales, they could get the firearms elsewhere where they wouldn't be subject to such age requirements or waiting periods, is what I'm thinking through. So would they just transfer their behavior? If the DoD applied these criteria or these policies, would it actually result in a reduction in firearm purchases? I didn't see any information on firearms that could inform that. So I started asking my colleagues about, where else might I see some of this information? And two that I found really interesting that they pointed me to had to do with cigarettes and soda machines, or soda for kids. So the first is for cigarettes, around 4%. So, and what this study did was look at, do people do American smokers go to reservations where they're not subjected to the federal excise tax for cigarettes? And we see it's, generally speaking, nationally, only around 4% of smokers will go to reservations to avoid excise taxes. However, that's among all Americans. When you start looking at specific states, especially states where there is a larger number of, or a larger reservation kind of component, the rates are much higher. So around 15 to 30% of smokers in Arizona, Nevada, New Mexico, New York, Oklahoma, and Washington will travel to a reservation to buy cigarettes to avoid excise taxes. And when they've removed sodas from vending machines and school properties, it really hasn't been shown to reduce adolescent drinking consumption of sodas. And I really love this quote. In summarizing the results, the author said, "It's unrealistic to expect a single target to have a positive impact with the obesogenic environment to which children are continually exposed." So again, some conflicting evidence that people will, convenience isn't a driver for where people necessarily purchase, and people are willing to go out of their ways to make purchases to avoid things like cost or potentially policies. So that made me think, what factors, from a research perspective, what I would want to know to inform this are, well, what are the factors that influence where individuals buy guns? We have a lot of data, and I showed you before, about why they buy firearms, but I don't know if we have a lot of data about where people make their decisions and what influences their decisions on where to buy firearms. Will gun purchasers shift their purchase behaviors to avoid restrictions? This is essentially what I've just been talking about. And then finally, and this I don't know, and I'm curious, is this just a military issue? Or are there, because interstate purchase of firearms, where one's a resident and where one buys a firearm, are so highly regulated, are there applications, like if we were to find out the answer to these questions, would there be application beyond the DoD and the military context where I've been thinking about it? And I'm not sure that there would be necessarily, but it could influence, in the absence of, the more I've been thinking about it, in the absence of a state that has a policy, if a firearm distributor or a chain, a retailer wanted to impose additional requirements for the sale of their firearms, will people just go to the next store that's available to them, or will they go to this store? So again, these are questions that I think warrant some attention. But again, their application beyond the military is something that I haven't really thought fully about. Okay, two more. So the next case study I want to talk about is preventing suicide among the unemployed. And again, I'm going to take a little slight deviation because this doesn't have a ton to do with gun violence, but it's something that I've been really interested in. So in response to COVID-19, I don't know if you all can think back to, or if you want to think back to the spring of 2020. So in March of 2020, we were at, historically low, relatively speaking, unemployment rates. It was 4.4%. And then the next month, it shot up to 15%. That was the highest increase in unemployment the US had ever seen. And given the uncertainty about the COVID epidemic and how long it would last and the effect on especially affected industries like retail or restaurant, entertainment, the service industries, people were really unsure, if you can recall, how long that period of unemployment would last. It turns out it spiked and then went down and has continued to go down pretty much since. But people but there's a lot of nuance there too, I should say. But regardless, people were really concerned, and people really started to make projections about the impact that COVID would have, and especially the exclusion policies on suicide rates, focusing almost entirely on this unemployment rate. So my colleagues, Lindsay Ayre, Stephen O'Connor, and I kind of tried to summarize the literature. Well, what is the relationship between unemployment, behavioral health, and suicide? So a lot of the literature, and that was used to make projections about how suicide rates would change after COVID, were based on ecological studies. And these look at this changes in unemployment and how changes in unemployment are associated with changes in the suicide rate. And they've really produced mixed results. Most of them have been from the Great Recession. So this one wasn't. This Lowenall one was from before the Great Recession, which is the Great Recession is that 2007 to 2009 period. But using data from 2008 to 2007, they found a 1% increase in unemployment was associated with around a 1% increase in suicide rates. These two other studies from the Great Recession found something similar magnitudes, that a 1% increase in unemployment was associated with around a 1 to 2 increase in the suicide rate. But this Harper and Buckner paper said, well, when you account for different trends in suicide, essentially before the period of unemployment, we actually find no effect. So it's still, there's a lot of evidence to show that they're associated. This 1% number gets thrown around a lot, but I just do want to highlight that it has been questioned. Let me just drink a glass of water. And so this is, again, what I said, just to highlight that data was what was used to forecast what people thought would be increases in suicide rates. I have to say there may be challenges and caution. We may use caution when we think about extrapolating what we learned from past recessions to the COVID pandemic and the unemployment during the COVID pandemic. And we highlight those in that report that Stephen, Lindsay, and I wrote. So first, the magnitude of change, as I mentioned before, from 4.4% to 14 whatever percent, was unlike any monthly change in unemployment we had ever seen before. So, this was really unprecedented. And so we're not talking about subtle shifts, month to month. We're talking about this dramatic shift. And so that caused a little bit of concern. Not all individuals were similarly affected. So, for example, in the Great Recession, the industries affected were very different than, things like automobile, manufacturing, things like that. Those were not necessarily the hardest hit industries that were affected during the COVID pandemic. And that, I show that below, sorry. But in terms of individuals, individuals have different risk factors. Even men and women have different risk factors. So we saw during COVID, a lot of women leaving the workforce who had a different, risk factor than men. And so, and a lot of them left for childcare reasons and things of that nature. So it's just a lot of different things that were going on that made the extrapolation a little bit hard. I just wanted to kind of highlight that quickly. But what we were thinking about was, okay, forecast or not, and I have to say our colleagues, especially Jane Pearson, was really instrumental in kind of forcing us to think that rather than forecasting or extrapolating, if we think that unemployed individuals might be at risk for suicide during this context, how can we support them? How can we reduce suicide among those who are unemployed? What could be implemented? And so we really thought, well, can mental health supports and can suicide prevention be implemented in USA job centers? And there is evidence to suggest that they can be. And this is work that, again, my colleague Lindsay Eyre did. Many of you are in Newark, are in New Jersey, and right north of you, Lindsay and other colleagues at RAND looked at what is they're considering calling mental health task shifting in community-based organizations. And it's called C2C in New York City. And what New York City did was they trained staff in social service agencies to receive training and ongoing coaching and support from their mental health provider partners. So there were mental health providers who trained and oversaw and provided, online kind of support for people working in social service agencies to administer mental health supports at a lower acuity level. So we're talking about things like mental health first aid and other training, motivational interviewing, problem solving therapy, things like that. They were trained reflective listening, trained in kind of those lower acuity mental health strategies that you might not necessarily need a licensed clinician to provide. And so the benefit of that is that you're reaching people at high risk, but a lot of concern that we have is the current supply constraints of the mental health system, that the demand for mental health services is so outpacing the supply of services available that, in C2C in New York City, they're thinking about how can we leverage kind of other professionals and, reduce demand so that those lower acuity concerns are mitigated early on in their course or that are addressed sufficiently. And there were some positive results. So what they found was that when implemented in job training and employment community-based organizations, task shifted, reduced residential treatment use among participants, reduced alcohol use, improved weekly work hours, and improved monthly pay. So there's a suggestion that this could work. So, okay, let's just start doing it all over the place. Why just New York City? Well, that's what we thought too. And I almost had as my title for the slide here, a tale of two webinars, because we engaged the National Association of State Workforce Agencies and said, what do you think of this idea? And they joined us for a webinar that we held on meeting the mental health needs of unemployed individuals that was sponsored by the American Psychological Association. So we had this webinar. It was a 2-day thing, and it was a symposium about how we could help these individuals. But in talking to the National Association of State Workforce Agencies, Lindsay was on a webinar for them because that workforce was completely burnt out during COVID. Remember thinking about all the individuals who were that we just showed that had lost their jobs or were in the process of losing their jobs, that were applying for benefits, that were not getting benefits. So these state workforce agencies were really, really burnt out. And here we come along thinking, well, let's meet the needs of unemployed individuals and train you all in some evidence-based strategies to help cope with them. And they weren't averse to the idea, but we had to recognize that they were also feeling very burnt out. So that made us think, well, what are some other strategies? How could we adapt this notion of task shifting? And so Lindsay and I, with support from the St. David's Foundation, are now launching a trial in Central Texas that we're calling Libraries for Health. And rather than train library staff in Central Texas communities on mental health awareness, we're placing peer support specialists. And peer support specialists in Texas is codified. They have to have been certified, go through a training, and part of that requires having lived experience in mental health or behavioral health. And so we're placing these individuals in libraries. And these specialists, the idea behind it, it's just started, is to provide a range of activities for both patron and staff to really expand mental health resources and awareness in those communities. All of the librarians themselves are part of a community of learning cohorts. So we're learning as we grow and they're learning from each other. And we'll be designing, we help design how this gets implemented, and we'll ultimately be evaluating the results from it. So that's one way that we've thought about, how we could extend the past work and the limitation, the context we saw, which may be some of the limitations of this task shifting model. Okay, I'm just looking at the time, making sure. I think I have 15 minutes to go through the last one, which I guess means I've been doing 15 minutes for each, which is good. Okay, the last case study that I have to present today is on mortality as a patient-centered outcome. So what do I mean when I talk about that? So also in 2020, in response to the COVID-19 pandemic, the National Action Alliance for Suicide Prevention, which is a public-private partnership that's really advocating for suicide prevention in a concerted, organized, and efficient way, created something called the Mental Health and Suicide Prevention National Response. We knew that this was something unlike anyone had ever seen before. We knew that a lot of people were stressed about the virus, were stressed about losing their jobs, were stressed about social isolation. So there was general concern that there was going to be a mental health aspect to it. And the Action Alliance took this on. After a series of meetings with members of the Action Alliance, they identified 6 priority areas in response to COVID-19. And I should say that these priority areas were they were twofold, I think. The first was to address the immediate need that we saw in the wake of COVID-19. But the second was to kind of use, I don't want to say use COVID-19 as a leveraging point, but really to kind of say, what has missed in this context? How can we, as we get through this pandemic, how can we prepare and support mental health and suicide prevention response nationally, moving forward once we're past this. So we have the 6 priority areas that were included in the national response. And I really want to talk about the 4th one, which is establish near real-time data collection systems to promptly identify changes in rates of suicide, overdoses, and other key events. I don't know if you're familiar with, I'm sure Mike remembers, people were like, oh my God, the data is so old for suicide. We have no idea. We can't learn anything in real time about who is potentially dying, and how can we target resources towards those groups that may be disproportionately impacted from a mental health or suicide prevention perspective. So there was a real concern, and so this priority area really addressed the need for real-time data collection. So we wrote up what we would call our calls to action within that fourth priority area. So the priority area was improved data collection, and then we kind of expanded upon that priority area. And this is an American Journal of Public Health, and this is what should be prioritized for improved surveillance. So again, I grayed out some of the calls to action. Some of them are create a mortality dashboard. Some of them are fund research to produce more timely assessments of suicides, perhaps leveraging predictive algorithms like nowcasting is what it's called. Our first recommendation, increased funding. I don't know, I should have looked this up before I joined today. I'm not sure what things look like in New Jersey, but there's over 200 death investigation jurisdictions, 57 reporting jurisdictions. Some of them are really efficient and use leverage modern technology. Others are still using spreadsheets and faxes to submit information about deaths that are occurring in their community. So there's a real need to overhaul and fully support the system that does death investigations so that we can get more timely assessments. But our third recommendation is to track and report survival as a patient-centered outcome for individuals with mental health and substance use issues in relation to key index events. And I'm just going to walk you through what we're talking about here and why we're talking about it. So this paper from Sidra Goldman-Malor and others looks at suicide rates among people discharged from emergency departments in California within a year. And so in general, we see higher standardized mortality ratios, so increased risk of suicide among those who are discharged who enter for deliberate self-harm. The rate is 693.4, and they looked at a comparison group. So they matched that group to a comparison group of Californians and found, that's over, 12 into 6, they present the standardized mortality ratio, but it's significantly elevated in that group with deliberate self-harm. It's significantly elevated among those who are discharged from emergency departments with ideation. And even among all emergency department visits, even though it's 23.4 relative to 13.3 of the general population, that's still almost twice as high. So those emergency department people entering emergency departments are at increased risk for suicide. And we know that because what Sidra and her colleagues were able to do was to link that emergency department data with mortality data to follow suicide risk within the year. Similarly, this is data from the Mental Health Research Network that looks at healthcare encounters 7 days before a suicide death. So in this study, they looked at those who died by suicide in their cohort of people within this mental health research network, and then looked back to see how many of them had a visit within a year or within 7 days before their death. And you'll see that around a third of individuals had a visit, but then again, you can see that it varies. So it's around, highest among outpatient specialty, where we see 16.3% of those who had an outpatient visit died by suicide within 7 days, relative to around 6.5% of those who visited the emergency room. So the point of presenting this is that, again, by linking healthcare visit data with mortality data, not only could we estimate where increased risk is, but we could see potentially where it's concentrated. And Michael Schoenbaum, who's one of my colleagues at NIMH, always likes to say this using a different terminology, but I think it's really good. As we said before, suicide is a rare event. And so people often say that it's like finding, trying to identify someone at risk for suicide is like finding a needle in a haystack. And that may be true. But what Michael likes to say is we can create smaller haystacks. So it's easier to find that needle. It doesn't need to be the universal population. And I think that linking mortality data to index data, as I'll call it, is the way that we're going to get to finding those smaller haystacks. So what do we mean when we want to track and report survival as a patient-centered outcome? Well, this is where I would suggest we start. So first, individuals with mental health and substance use issues, perhaps those with diagnoses within health plans. Let's look at those individuals and see, when and where they die. In relation to key index events, and so for example, what we talk about in the paper is emergency department presentations for suicidality or overdose. So again, we can see whether those individuals are at increased risk for suicide. We found it for California, but does it hold elsewhere? Upon discharge from inpatient and mental health and substance use treatment. So those three are pretty clinical, but I also think we should be thinking about suicide risk as a patient-centered outcome for non-healthcare events. And you might think returning citizens, individuals who are being released from prison or jail, what do their suicide rates look like? Or maybe even, adolescents exiting the foster care system when they turn 18. What does suicide look like in that sense? Because I think that we could indicate, and we could do the research very carefully to identify, where we see these risk cases. So I think that this is a pretty good idea. And I think that we have a lot of sales. So again, well, what's the context? Why isn't this happening? And many of you researchers who are on the line may already know this. The first is that a lot of state or local offices where data is collected or compiled may not have the capacity or resources to link data. As I said before, these are very underfunded systems usually that need a ton more resources than they're currently working with. So if a researcher comes in or a healthcare plan says, can we link all of our data to your data? That might be asking a lot from them. It's not as easy as it perhaps could be. So there is national data. There's the National Death Index. That would be great. But again, with the National Death Index, the problem that we might encounter there is that the delay. So if the National Death Index data for 2020, I think it's available for 2020 right now. So it's not even available for 2021. So if you wanted to look at, you would have to look at, in a very historic way, people who exited any of these systems in 2019 or 2020 and how that was related to their suicide risk. But it doesn't necessarily tell you what's happening right now. And obviously we would want something that's happening now. Again, state and local resources might be better if they're more timely in getting you what's happening right now, quote unquote. But again, they might be under-resourced to do that. There's also, we really have to be thinking when we're talking about linking data on privacy concerns. So we have to have privacy protections in place. A lot of researchers, this is part and parcel of our work. We put things through IRBs and we have protocols and safety protocols to ensure that privacy is protection and risk of disclosure is minimized. But should we just be asking researchers to do this? Or should we be asking hospitals and healthcare plans to do this? And I think that that's, warrants some serious consideration. There's also certain suicide cases that may face additional scrutiny. So for example, in the study that I did on psychological autopsies in New Orleans, I only looked at suicide cases. I did not investigate homicide suicide cases because those legal proceedings were going on. So as a researcher, I'm not going to get involved with that. And so that might be something that we need to consider, what gets included or what is out of scope. And then finally, the one that I think is actually perhaps most interesting, I guess, is that there is something called a sentinel event where if something is identified by a hospital system, it requires an investigation. And a suicide of any patient within 72 hours of discharge from a hospital is considered to be a sentinel event, which requires an investigation within a year. So if hospitals routinely start linking their case data or their discharge data to mortality data, what you'll see is you're likely to find more of these cases rather than just finding them ad hoc when you learn about them. So if that's a routine procedure, you're doing that. And not that sentinel events are necessarily punishment, but hospitals and healthcare systems are looking to minimize the number of sentinel events they have to investigate. So again, I think that that's a real concern. So those are my 4 case studies. I think I'm ending a little bit early. I hope that that was informative to you. It's what I've been thinking about and what I spend a lot of my time. I'm sorry that St. David's Foundation logo got inserted on these slides. But that's what I've been thinking a lot about, and that's what's kind of keeping me motivated. And as I think about new research ideas, that's what I'm doing. And I really just do think as researchers, and it's not, I don't think it's necessarily all researchers need to do that, but you've got to ask the questions and conduct the research. And as Mike said, they're prioritizing doing research with the community, not in the community necessarily. I think that's really insightful. And that's where you're going to learn about those constraints and thinking about, why is this research idea I have, why isn't it gaining traction? And I think that understanding the context is important. And I don't think we should be giving up once we understand the context, but I think it drives more research, more targeted research. It's not kind of running to the finish line, it's running around the track. And that's kind of what I'm motivated by right now. And I hope the researchers online are too. Please email me if you have any questions. I'm happy to share my thoughts. Sorry for ending, I think 3 minutes early, but hopefully that saves time for questions, Mike.
Yeah, absolutely. First off, thank you everybody for logging in again and continue to put your comments in. We're catching them and putting them aside. I'm going to read them in a moment. And then Rajeev, thank you for the great presentation. We have had some comments come in. I'm going to start. I want to prioritize viewer questions. So I have, like 18 that I wrote down, but I will just ditch them if we run out of time, and start with the ones that came in from the audience. And so the first question came in, and I know there was a response to this in the comment section too, but in case people weren't reading that, I wanted to give Dr. Ramchand a chance to respond. So one of our attendees, Carla, asked, why is the term firearms used instead of guns?
Oh gosh. I don't actually know if I have do you have an answer to that, Mike?
Well, I mean, my understanding is, so guns is a broader category. So like a potato gun is a gun, or a BB gun.
Got it. Yeah.
But the firearm refers specifically to the actual sort of like chemical reaction that allows ammunition to be discharged. And so like we're just focused specifically, potato guns are less involved in the stuff that we're talking about.
Yeah, sure.
Yeah. So we keep the firearms. And there's a little bit of research showing that firearm owners prefer the use of that term over guns. I think it's trying to map onto.
Yeah, I have to say, I was not super conscious about, because I did use the term gun owners in there, and I kind of interchanged it. So yeah, that's good point.
So hey, our second question came in from audience member Frank, who asked, are state laws regarding firearm purchase and sales applicable on U.S. military installations? So for instance, do New Jersey military members have to go through the same process as a civilian living in Pemberton, New Jersey, for instance?
Yes, I believe so. I think that it's not, I do think that that's the case right now, that the state policy kind of oversees that DoD policy. I will say that when we are communicating the responses, and this is, Craig Bryan was also on the committee, and this was like really his insights, is thinking about the policy requirements is similar to the military's requirements for motorcycles and motorcycle safety, which really go beyond what's required by states, and state laws on motorcycles also vary. But DoD policy is pretty consistent, and it requires, taking a course, things like that, because also motorcycle crashes are a huge cause of both injury and mortality among military personnel. So they've addressed that. And so we've tried to model these, or the implementation of these, to kind of coincide with kind of how the military addresses motorcycle safety.
Our next question came in from Karen Cantor, asking, how does moderate evidence differ from strong evidence? So I know you're using those terms to describe the evidence base for various prevention approaches.
So in the Gun Policy in America initiative, the criteria we use is the quality of the research study, the strength of support, the number of studies, and whether it uses overlapping data. So for the last criteria, if you find if the same data is used and you see the same policy effect, it's kind of, we discount it a little bit because it's the same thing shown twice. But again, so it's independent, it's the number of studies, the quality of the research design, and the data source, essentially, and the combination of those factors leads to what we call limited, moderate, or strong evidence.
Yes.
There's more. There's a whole documentation on the Gun Policy America website you can read about.
Our next audience question actually also again came from Frank, and it's what agencies are responsible for reporting suicide data, and who's this information reported to?
So that's a great question. The responsibility is, I mean, that varies by local jurisdiction. So a death investigator, and there are states have death investigations, so it's centralized within the state, and then there's some community states that have more local jurisdictions. So what happens is the death investigation happens at that level, and then it gets reported to the medical examiner, and then it gets reported to the state reporting agency. And again, there's like 57 of those. So like New York City has its own, it's separate from New York. And then those reporting agencies voluntarily share their data with the CDC. So everyone thinks it's like the CDC's delay, but it's actually a voluntary currently, and all death investigating centralized locations do this. But that's the reporting. So we talk about delays in the data. That's kind of where it comes from, right? Is that there could be a place that's doing it like super, super quickly. But the national data is kind of limited by the slowest reporting agency, to be quite frank.
So I should go easier on the CDC is what you're telling me.
Well, I mean, there may be ways that they could be more efficient, but, and also death investigations can take time. I think that it's like only 50% of suicide cases are identified within 2 months of the death, because, these are investigations. A lot of death investigations, they don't leave notes, single car crashes. You may have to in New Orleans, the study I did in New Orleans, I remember, you may, if somebody falls from a parking lot or a building, for example, you may need to identify, you may need to think of it like you may need to get the video to see whether they were jumping or whether they, and you have to work with the police, and sometimes medical examiners and police work really well together and sometimes they don't. So there's a whole host of reasons. But in terms of responsibility then, so it's a hugely voluntary system. The National Violent Death Reporting System also is tracking suicides, but again, and more states are included. I think all states are now included in it. But for a while, it was just a limited number of states that were including, and that provides a little bit more detail on suicide deaths, but it doesn't have denominators, so it's really hard to estimate rates.
Okay, so I'm going to do one last question, and this isn't exactly a question from the comments, but there were some comments about ERPOs, extremist protection orders, or what some folks call red flag laws, and I think the concerns that the viewer were expressing come from a thing you hear a lot that I thought maybe you could speak to for a second, which is, to what extent do ERPOs contradict the idea of due process, or do ERPOs typically involve due process where people are able to sort of present their case for themselves?
That's a good question. I mean, I think that's a better question for a lawyer, to be honest, than it is for me. I'm just, a number cruncher, but that's a good, again, I think that could be, I mean, like, that's like a great question, because these ERPOs are really new, relatively new. And I think we're just learning about them and learning how they're applied. I think that we have found out, right, that they get used much more frequently for self-harm than for concerns about harm for another individual. So that is interesting, the due process. Yeah, so again, I'm sorry, I can't really answer that question.
No need, just putting the question out there. So hey, we have time, and I don't want to steal from this coming, but I want to thank Dr. Ramchand again for a great presentation and for engaging with the questions from the audience. I know we didn't get to everybody's thoughts and questions. Hopefully you can reach out to us or reach out to Dr. Ramchand in the future with things